Okay, so we have one case from Homolka. This is not neuroablation. This is, again, the last case of pulse field ablation of pulmonary veins. And then we have 3 cases and 1 pre-recorded of neuroablation, which will follow immediately after. So let's start with this case.
Okay, thank you. Good morning, everyone.
Good morning.
Welcome to Homolka. We have a patient on the table, persistent AFib, and we're gonna introduce patient quickly and technology and our data quickly because you already listened one lecture and saw one live case yesterday. So let's go.
So this patient is 63-year-old male. He's quite obese with body mass index 35. He has AFib anamnesis since 2022. He has paroxysm even on amiodarone. The amiodarone was discontinued for bradycardia. From interesting echo, he has dilation of left atrium with left atrial volume index 41. Here you can see some ECGs. One is from Holter ECG when he was referred to us, and the second ECG is from yesterday. While on department, he had 1 paroxysm of AFib. The important information is then when he had Holter monitor, he was mostly in AFib for 60% of the time. So it's more like persistent AFib.
Okay, here's a system overview. As you listened to lecture yesterday, let's go quickly. We have 2 sides of the catheter because the patient was more persistent, so we chose 30 milliliter big one for this case. As you see the catheter animation on the right panel, it is bipolar, biphasic, and all the odd numbers and even numbers are the same. It was like a plus 1, 2, 3, 1, 3, 5, 7, 9 will be plus, and then the other even numbers will be minus. So then we can create the whole field around the catheter. That's the most, the biggest advantage of this technology. Let's go next. And quickly go through the Homolka experience. Since last year, we experienced some cases, and in total, in this clinical study, as this device is not approved like CE mark or FDA, and more than 100 patients were treated in this study, and among them, we did over 35 patients treated here in Homolka Hospital. And so far, 100% success, acute success for all the patients. And at 3 months, no patient had a recurrence at 3 months. And of course, safety endpoint is no major complications. And this is one example. Then we're gonna show during live case. Go next. And we have some experience like non-PV lesions. Go next, the slide. Okay, yeah, this is an example of the mitral isthmus. We had a mitral isthmus during the case, and we did 1 application, and we terminated mitral isthmus. This is an example. And go next. Not many cases, but we also did a CTI with technology after giving a nitrate. We did 1, 2 applications on the CTI, and we confirmed the block. Okay, let's move on to the case. Yes. So let me just go quickly through what we did before the live transmission. This is an NSAID map with HD grid. We created this map during sinus rhythm, but please just we have to note that patient came with atrial fibrillation. And before the transeptal puncture, spontaneously AFib terminated into sinus rhythm. And we induced AFib because the patient sounds like more persistent than paroxysmal. Let's go to the review screen, Pulkar. Can we show the Pulkar review? we tried induction after the voltage map. Can we go for the Purkar review? Wait, okay. Yes.
Yeah.
We induce AFib and then somehow organize into perimetral flutter like fast AT or organized AFib, but cycle length was 190. That was too fast as a perimetral flutter. And then this organized into AFib again. So we decided to do left veins first before the live transmission. Okay, let's go back to the Navix.
Toshi, can I ask you? It's
Yes.
Peter. Actually, can I ask you?
Yes.
I was not here like since the beginning. So you
Yes.
are using the bigger, like larger catheter or smaller?
Yes, exactly. We
Oh.
open the bigger catheter because the
Bigger.
patient is more persistent. Yes.
Okay.
We're going to show you the two catheters side by side during the post-map, but we have to finish the case first. After we finished the left veins, we did 3 applications, one on the RSPB and one in the LIPB and just between on the carina. And then AFib terminated. Oh, we have a review, but we can skip it. Okay. Yeah, this is it. After the third application, AFib spontaneously terminated, and we never induced AFib or AT. Okay, go back to the map. And I said we used the Navix mode, which is based on impedance. So the catheter has no magnetic sensor, but because we do the procedure under the GA, it fits well. You see the shadow, one on the top and one on the bottom and one in between. And then can I see the region tags? This is a kind of region estimation based on the calculation. Right, okay. So the plan is to continue the right veins and posterior box because we opened 30 millimeter, but this termination was somehow we didn't expect in this procedure. Okay, so then you see the fluoro image and the 3D mapping system, and let's go to the right side. And the manipulation is quite straightforward. Just see the map and X-ray. We go close to the RSPB and put the catheter not to have two electrodes touching each other. We have good signal. And rotate to the left on the map, please. Yes. Okay. The ice is good, signal is good, map is good. We can ablate. Okay, let's go. Yep. If you have any questions, comments, please let me know. So
Actually,
we
are
just
you
started
using
the
all
first
the
application.
elements of the catheter, or do you have some arcing issue or not?
Oh, that's a good question. As you see the monitor, the plus minus are blinking, and all electrodes are touching on the tissue, and we have no arcing, no issues. And we just finished the first application.
Toshi, do you
Yes.
think that the arcing issue is more pronounced in the smaller catheter or in this catheter? This larger?
Yes, Peter. That's what I felt last time, but this time I would say 30 millimeters. Oh, collision. We have to say that it's collision, but no arcing. But yeah, 30
No, it's not
millimeters.
collision, it's
quite-
arcing.
Yeah. Okay, go next. RS posterior.
They are sensitive
But
about
w-
arcing, but it's probably a little bit problem with a lot of PFA technologies.
Right. But the good trick is if we open 30 millimeter catheters, the bigger one, we have more electrodes as we're going to show later, but we can just put the distal electrodes in the vein and pull back the catheter a bit more proximally, and then we have to avoid any interference of these electrodes. Now we moved to the inferior. Ice is good, signal is good, map is good. Oh, it's more like carina, but let's go.
So the plan
Shadow.
is, Toshi, the plan is going
Yes.
for 3 applications per right-sided, or what is the plan?
Yes, the average, let's go. Application should be 5 on the left side and 5 on the right side. it depends on the anatomy, but in this case, you see the map, RSPB is quite big, so we have to stamp around like one anterior, one posterior, one roof, and maybe two inferiors. It will be 5, or maybe one more on the carina.
And because it's like a persistent AFib, so after
Yes.
right side, you
Shadow
will go
go.
for posterior wall or not?
Yes, absolutely, yes. That's what we planned before we start the first application. This patient is more persistent, like from last
Okay,
year.
fine, I
The
understand.
patient had, yes, more than 60% AF burden, and he came with AFib. So we would go for
So,
PVI
but
both sides.
after all, if you plan all this, like, I mean, actually, Alan showed yesterday the same thing, and I don't remember if he used a smaller or larger catheter, but actually, to get
Shadow
pronounced
go.
that you have single shot catheter or single shot technology, it's hard to understand if a single shot is technology with 5 applications per side, right, or per left or right. So
I think we should talk about simplified PVI technology or something like
No,
this.
because-
Obviously, none of them is a single shot
No,
except of
but-
maybe cryo.
but you know, the industry likes to pronounce, okay, we have a single shot. It's like,
I think it
everybody is speaking a
It
single
doesn't
shot.
matter. The main thing is it
does
works.
matter.
Yeah, it
It
doesn't
does
matter.
It does
Shadow.
matter.
No, I don't think it matters.
It does matter.
Well, but let's go. We're doing posterior wall right now, but that's a good point. Single shot means just one application in the vein. That's ideal. I know, I understand, but normally we have, various, it depends on anatomy. Everything depends on anatomy. If it's small vein, just 4 veins, go straight forward, that's okay, but that's also common with the other technologies,
As I
not
mentioned
specifically this
today
one.
already, if you take 35
Shadow.
millimeter big device, you just need maybe 2 applications in one area of posterior wall. You are overlapping significantly. So with few applications, you can burn the whole posterior wall easily because that's not so big as we expect. We have some
Right.
false understanding how big is the atrium from all these maps, but in reality,
Right.
it's quite small thing. So I think that's the easiest way now
Shadow.
compared to previous times where we tried to
Let's
do
go.
box lesion with RF and being afraid of creating some problem with esophagus. Today it's so easy to ablate the whole posterior wall with pulse field. And
I see.
it seems to be efficacious because when we do a redo case and map with Affera, practically always there is posterior wall completely isolated or silent. So
On the other hand, I understand your comment. With a large, you can
Area.
cover large area, but it depends on the contact.
Shadow.
Doesn't mean that large catheter, it's always touching
of course.
ideally the tissue, right?
but that's relevant to every ablation. If you don't have contact, you do not have good reason.
But it's larger doesn't mean that you have like large footprint. Okay.
Oh, you have.
No, you have
A large
it
footprint
depends,
is
but
there,
depends on the contact.
Yeah, of course. But this is
But maybe
Toshe,
yes,
what's the progress?
the
you are
progress
finished
is we
with
are
the right
finishing
side, or-
everything. Yes, we finished PBI and right veins and box isolation, and we are mapping very soon. This is the last application, just additional on the carina anterior right side. And the good thing, yes, about the discussion just now, as the catheter is fixed, we cannot change the diameter and we cannot change the shape. We have 2 sizes, which is a bit better. At least we have some, selection for the strategy. So the ablation is done. I just checked all around with this catheter. We could map there, but I don't want to show the
Toshe, can I ask
map
you
with this.
how many lesions, how many applications you did on the posterior wall with this large catheter to satisfy PEPA to get like single application on the posterior wall?
Well, I did very well overlap on 3 applications on the posterior wall.
Okay, so
Just
he must
3.
be happy. 3 applications per, you have 5 applications per veins, but you have only 3 applications posterior wall. This is perfect. Okay.
Yes, because
He
we
sounds
cover
like
really
happy. He
antral
seems to be
PVI.
happy.
I'm
Okay.
happy
You
all the
made
time.
Pepa Kautzer happy. Okay, it's a good endpoint of your procedure.
If 2 professors are happy, I'm happy.
So should we move somewhere else? So the plan is you will map afterwards. You can
Yes.
maybe if you have like 2 minutes.
I'm gonna map during it.
1 minute.
During the mapping,
No
let me
minute.
show the actual
Pepo.
catheter side by side.
should move
Veronica will
soon.
show
Okay,
the
so-
Well,
catheter.
they can reconnect after a while, but
Okay. No, they don't need to have recording. So just map or not map.
we believe that this will
I'm
be
gonna map and Veronica
so
will
you
show
can
the
show
catheter.
us just put it in the middle of posterior wall so we see what is the signal.
Toshe,
Yeah, we will do that. Yes.
Toshe, don't show the catheter.
Okay.
Look at the voltage. Okay,
Show
on the
just
posterior wall.
voltage in the middle of posterior
Oh,
wall.
okay.
Don't,
They're
don't
showing
take
the
care
catheter.
of veins. We believe
Can
that
you
veins are
just make
isolated.
voltage on the posterior wall?
Oh, now
You have catheter there, right?
Point.
HD grid. Okay.
Yeah, okay,
please.
so then-
Okay, nice.
I do both. Yeah, I'm showing map and catheter on the side. Is it make sense? Does it make sense?
Go to middle of posterior wall.
Joseph wants to
Yes.
see posterior wall ablation. Okay.
Yes, sir.
The results.
Yes.
Okay. Don't show
Yes.
us the catheter. We saw
I'm
the catheter
touching.
yesterday.
Yes. The catheter is in the sheet.
It's better to take it
Oh,
out
new map.
because otherwise
Go for
it
new
does
map.
not map.
You know what? Look, he's mapping
Go for new map.
veins. Why you are
Or-
mapping the veins? Okay. Map the posterior wall. Okay, perfect. Now, go.
Oh, he said we have a shift and we have to create a new map. Okay.
Oh,
Okay.
we have.
Okay,
you
we can
have shift.
go
Okay.
quickly new map.
Okay, I understand you have sheet, but you have shift. Okay, fine.
Yes.
Can you just adapt this position? In this position, can you show the voltage?
Yes. In the middle of posterior wall. I believe this is in the middle of.
Yeah, there is
posterior
nothing
wall.
on signal side.
No
If
signals.
I can
Look,
see.
it's no signals.
Yes.
You don't need to have
Yes,
any
I
colors.
can show the
Okay.
eyes here.
Okay. So guys, Toshe, Veronica, thank you for excellent presentation. I think it's
Thank
like
you.
second time we see this battery catheter. Okay.
Yes.
So, okay. So, are we ready to move to other labs, Peppo?
Okay. Thank you so much.
Okay. Thank you so much. Okay. Congratulations.
We are online?
Oh, fantastic.
Okay,
you
great,
wanna show this
great.
first?
This is perfect. Yeah. So maybe we can start with the. Okay,
So-
hi. Do
Hey,
you hear us?
Pascal.
We don't hear you.
We see you now and you have now time for
Můžeme to dát na
presentation.
hlas ještě více? Neslyšíme. Okay, we
Predrag.
can.
Prodrak.
Okay,
Prodrak.
super. Predrag.
Predrag. I know Prodrak.
Okay,
You know,
so
I
this
like
will be a
Prodrags.
case of cardio-neuroablation guided by CartoSound FEM software. This is a young 38 years old male with reflex syncopes. Actually, he had a syncope during, it was a situational syncope. First episode was in 2022. And he had a head-up tilt test showing the cardio-inhibitory reaction with the asystole lasting for 21 seconds. So we know that is some kind of reflex sinus asystole, but we don't know what is happening at the level of the AV node. In 2025, he had an atropine test showing a very nice response with the heart rate reaching 100 beats per minute in first minute, and at fifth minute it was slowing down, but the baseline frequency was 65. He also had the diagnosed segmental pulmonary embolism, but this was an incidental finding and doesn't have to do anything with this reflex bradycardia. So he is on an NOACs, and he had a normal ejection fraction and Okay, let's show the next slide. So this was his ECG on admission, unremarkable findings. Okay, and so far we will show you what we've done so far. So we have a standard double jugular access for the purpose of extracardiac vagal nerve stimulation, and here we have a very nice findings. We will show you in a while. We have one transeptal sheet. We have obviously ice, and for the purpose of this case, we are using CartoSound, including FEM software. So within a few minutes, we were able to reconstruct the anatomy of the left atrium. Can we show? Yeah, you see it. Okay, can you rotate the map just to show the anatomy? Okay. So this is a obviously very small atrium because it's a young patient without comorbidities. And with this software, we were able also to tag the fat pads for the superior paraseptal ganglionic plexi. And we also tag the phrenic nerve. We also reconstruct the right atrium using this software. And on top of that, we did standard electroanatomical maps of the left and the right atrium just to compare with these maps. Okay, so usually in all patients, in all CNA procedures, we are starting with the EP study, with the basic EP study, and after that, we are tagging the phrenic nerve. We are checking the breakthrough of the sinus node. And after that, patient is fully relaxed, and we are performing extracardiac vagal nerve stimulation. So before Pasquale will explain you the CartoSound, I would like to show you something that Professor Pachon showed you yesterday and today, and it is a VAFIT protocol, so vagally induced atrial fibrillation. So here you can see, yes, you can see it there. So show them ERP first, normal ERP. So we check okay, so this was the coupling interval that was not capturing the right atrium, and it was 180 milliseconds. So this is a baseline. And then we repeated the same thing during extracardiac vagal nerve stimulation and showed them the next slide. And we were able, with one extra beat that has a coupling interval of 120 milliseconds, so far below the refractoriness, baseline refractoriness of the right atrium, we were able to induce AFib. So, and so far we did like in 5 patients this protocol, and in all of them we were able to induce AFib. So this is very, very interesting finding. Okay, so if you want to explain the CartoSound.
Yes, I don't know if there is any question first about this part for you, or no?
Yeah.
All right. Okay, so as we discussed this morning, I mean, this is fairly simple. So the very first view, you advance your eyes to the SVC, you see
big eyes on the screen, please.
I don't know if you can see the eyes, you can also see the CartoSound there. Anyhow, so you see the right PA at the border. So the very first structure is the SVC, and this area here is the fat pad here, between the right PA, which is this circular structure here, the right superior pulmonary vein, which is this other structure here. And you see the fat extends actually a little bit more septally in this area. So it's kind of like quite large of an area. And yeah, we already constructed. It's roughly what the purple is. I think it does extend a little bit more septally and down this way, honestly. So you see there is fat in there too. Maybe you want to take this other contour. But anyhow, that's the area right underneath the right PA, between the right superior and the septal SVC. And for the inferior fat pad, which won't be the target today, but I mean, you see the coronary sinus there. And basically what you do, you counter-attach more. There is not much fat there in this particular patient, but that's where you see it, right there. There is the CS there, the left atrium on the other side, and the fat on top of the coronary sinus. That's the other inferior paraseptal fat pad. But I understand for this procedure, the patient only had I mean, we don't know what happened to the AV node until we get rid of the sinus node and the innervation, but because the patient only has sinus arrest. But I think this would be the primary target, right, President,
Yes,
for today?
definitely.
Yes, that's will be consistent with what I would do. For the phrenic, by the way, you continue going more posterior, and you see this bend here. I don't know if you can appreciate it. Let me see if I can show you better. Now, there is a bunch of catheters in there, so...
Can you show them eyes on the main
Here.
screen, please? Because we want to... No, but we want from the eyes
Right here.
machine. Is it
I don't know if you can
possible?
see that bright band. So the very first, there are two catheters in the SVC. You see them, but then you see the SVC wall, and then the band that is outside the shell. That's actually where the phrenic nerve would be. And of course, we validated that with high output pacing. I don't think it's truly always necessary, but I mean, in this case, we did it. And that's the phrenic that extends more inferiorly here. And you can see also here very nicely. I don't know if you can appreciate. The very first one is a sheath going to the SVC. Then you have the SVC wall. Then you have fat, which is the extrapericardial fat, and you see the phrenic nerve in that position. All right? And for the ones that like anatomical sinus node, that's what it would be around this area here, where the arcuate ridge is, right where the junction between the SVC and the appendages. That's where the sinus node is always located. You can see also the crista terminalis here and so forth. But anyhow, so some anatomical views, but the area is always this overlap between the SVC, the septal, right superior pulmonary vein underneath the right PA. That would be also the same area.
Yeah.
Yeah.
Basically, this is the same approach we are using here,
Yes.
but without Cartos sound. But we are using basically the same landmarks
Yes.
for this hotspot. Can we show them the electroanatomical map of the left atrium and the right atrium? Not FAM, just our maps, without transparency, without this eyes, please. Left atrium. Show us left atrium, normal left atrium, without FAM, please. Okay. So only left atrium. Only left atrium. Okay. So this rotate to the right. So this is our hotspot or P point, as Professor Pachon
You
said.
could leave there this.
So I think
You could leave there in the map this this area of the ganglion
Fat pad.
plexi or fat pad. It was
Yeah.
there,
okay.
so we can compare.
Just fat pad.
How far? Yeah.
Okay.
So it's
No,
quite
this is
close.
phrenic nerve.
No, that's the fat pad, yeah.
That's the fat pad.
Yeah.
Can you rotate the map just to see how far we are from here?
It does extend this way too.
Yeah.
I mean, if you can, we didn't reconstruct it all. If you go live on the fan, on the Cartosa, on the actual map, so you can see what I'm looking at now. Can you show the fan? No, the fan, the sound fan on the map. Yeah. So just show the catheter. Show the yeah, the thing. Yeah, there we go. So this is actually, you can see here, it does extend septally this way. So that's the fat pad. You guys can see it, right? So really, that fat pad will be more on anterior side, because we're getting close to the aorta there. So that's the paraortic. But here, it's really, you can appreciate that it's fat in there too, right? And down here, I don't know if you can see it. You guys can see that triangle there? So it's actually a little bit more septal. So we can get another slice
Yeah,
here
yeah,
and
maybe-
connect it. Don't connect it to the phrenic nerve. Connect it to the purple. Yes. Yeah. Oh, okay. That's fine. There is a little bit of current leakage. That's okay. But you know, you've seen it. I think some of it is from the Pruka.
Something is happening with the, I don't know, with the PIO or new cable. Okay. Okay, but definitely, what's your preferable approach to go biatrial?
Yeah, we got start from the left side first.
Left side
and
first,
then,
and then
usually, I mean, I do it right at the center of the fat pad or towards the right vein. And then usually after one lesion, two, you see an increase in heart rate. And you can retest stimulation at that point. Usually most of the time it's attenuated or completely gone. But then we're still going to cover the full area.
And,
Yeah, it's about 3 centimeters square. It's not that much.
Yeah, and what about the AV node? Because in some patients are coming back if you do only selective
Yeah.
ablation or denervation of the sinus node, they can come back with the AV block. So, are you performing denervation of the AV node in all patients?
Not in all, only in the ones that either come back or the ones that clinically documented AV block. I mean, most of the times we don't know because the sinus node masks the AV block, exactly as you said. But the lower ganglia is a little bit less forgiving because we don't know how close we're going to be to the compact AV node. The AV nodal artery may run through that and other things like that. So here, I mean, now the Cartosound fan is actually facing the septal portion of the... And if you can see the yellow dot, I guess the yellow dot is your target?
Yes.
So that's still inside. If you guys notice, that's actually the fan that is crossing where the yellow dot would be. It's still inside that fat pad. So...
I mean, the distribution of the fat pads are, you know, fat is everywhere around the heart, right?
Yes.
But
it tends to be
there are
clustered
some
in this area.
clusters, yeah.
Yes, yeah.
I think with Cartosound, that Cartosound offers a really minimalistic approach. You just in few minutes you have the biatrial map, and you just put the catheter there and go. And you have ISO. You can do easily transeptal. So. Great.
But as we discussed yesterday, the most importantly, these maps are real. I mean, because it reflects real anatomy. It's not like if you are mapping with your catheter, because if you do not touch any area, it doesn't exist in the map. But here you have a clear reflection of pure anatomical picture. So I think that's the main advantage of this technology, I think. And today it's much easier than it used to be in the past, because you had to draw contours. So now it's doing it quite fast.
Yeah, it's basically graphical
So
presentation.
maybe
what
you
we
can
see on the,
you can start ablation.
Okay, let's go and
start ablating.
You have
ablating
about 8 minutes
we will cross.
to
we
go.
will go back.
You have to cross again, yes.
Yeah. Okay, let's cross this. Okay, and can you show them show them the responses of the sinus and the AV node to the vagal stimulation? The problem here was that we had a lot of junctional beats, so we don't actually know. If what's the true responsiveness of the sinus node. That's an issue. Okay.
Yeah, right there. I would say it like.
Yeah. Sometimes we are doing like a T-shape ablation in this. So.
But you will do ablation and we will check. So we will see what's going on. Huh?
Yes, and I'll follow you on ice if you don't mind, so we can sort of see where you are. You're a bit inside PV, but it's okay. Yeah.
I will go out. I'm just waiting for the catheter to. Not flushing.
Oh no.
And can you show them also? Okay, these are responses. Do you see the Pruka screen review?
Yes.
Okay, they see. Okay, just show them also the signal here we recorded in front of the.
Yeah, right here. See?
Yeah, right
in the
here.
center of the fat pad. I mean, you cannot see it. It is purple there. You see. You can also see fractionation.
Yeah.
Can you speed up?
The problem with fractionation that I have is that if you ask 3 Ps what fractionation is, they give you 3 different answers.
Můžeme ablovat? Je v pohodě? Okay, otočit mapu do... Jo. Okay, I would start here.
Yeah,
so slow down on Pruka, live Pruka, please. Yeah, our CS in the right atrium, right, because of the Buffett. Okay, what's the heart rate here? 51. Okay, go here. So we will ablate 35 watts and ablation index up to 500. Go here. Okay, we have some speeding up, but it's not what we expected to have. we have problems also with the stability. Okay, stop. We'll go a little
Yeah, try
bit.
touch higher, yeah.
Yeah, a little bit higher. Můžeme zvětšit mapu, prosím? Okay, let's go here. We have a very nice contact of 20 grams. It's moving. Yeah, now we have a very nice response. And you see, we had to go more septally to achieve this response. Okay, stop here. Okay, so we had only 2 applications. Can we do vagal nerve stimulation? I
Yeah,
will
usually
just-
this is enough for most cases.
Yes,
It's
yes,
amazing.
yeah,
Now.
yeah. Let's check let's go
So-
inside and,
Yeah, that's good.
okay. Okay, so let's repeat the vagal nerve stimulation, please. Patient is obviously fully relaxed, and you see, no, do you see the live screen? Yeah. So no sinus node slowing. Okay, great. We have a, okay, so, but this is usually not enough, right?
Yep.
So we have a nice acute response, but I think we need to do a little bit more. So probably the strategy is to go to put one more application here, because at least 3 applications we are giving here, and then we will go to the right atrium to ablate also at least 2 applications. And in my opinion, I think AV node innervation should be performed here
Actually,
as well.
we have a question, guys.
So I mean the
Sebastian Stek,
Yeah.
you can also see there is no AV block during this stimulation, so you probably have a denervation of both nodes, sinus and AV block during
Yeah.
sinus rhythm.
Yeah, but we are doing only right vagal nerve stimulation. When maybe we can
this
see
is the
from
left side. Yes, yeah, we have the left scatter there.
Let's go from the left side. Wait, I will just check if it's still at the good
good.
position.
Yeah.
Okay, let's go here. Let's check the left vagal nerve stimulation. Go here. Můžeme stimulovat? Ano. Okay. Okay.
So yeah, man, maybe we shouldn't be doing the inferior node, because really, when you have this type of response, it's pretty much it's fine. You just do
It
by
looks good, but
Yes.
yes. This was a left vagal nerve stimulation.
Yes.
Okay. Okay. So any questions from the audience?
So I mentioned today that you can stimulate both nervi vagi, and then this was left-sided, and there was still no block, so no response. It looks like it's effective, and they will do, if I understand correctly, from right side, but you will not do AV nodal area down. Is that correct?
I'm afraid we don't hear you.
Yes,
because
actually
there are
the
some
question
technical
was,
problems.
if you continue from right atrium, from right side, can you hear us? Oh,
Yeah, now we can hear you.
Oh,
Okay.
very nice.
Go on.
So Joseph asked you if you want to continue now from right side, from right atrium.
I don't hear them.
If you-
I have also a question that how you can confirm that you
we
Yes,
can
yes.
go and ablate from the right side. Yeah, definitely. Okay, let's go. Give us the map of the right atrium.
We have one question here in the atrium, Hassan.
my question is that how you can confirm that you really captured vagus nerve when you did the spacing? Maybe you
I
just
I don't hear them.
based on the stimulated
There we
on
go, it
the
should be opposite
empty
already.
space or what?
Actually, you should start
Can you
the
solve
testing
these
in the beginning.
technical
In
problems,
the beginning
please?
of the procedure,
Because we don't
we
hear them.
always start to pace like left and right. Okay, it's always some.
Show them
the
the.
pacing catheter?
Yeah, they see the map. Okay.
It should be
That
stable.
one in
Should be stable.
jugular.
Okay, now we hear
No,
you.
they did not move.
Now we hear you well.
You
Can
have
you
very
repeat the
high
question? We went
in
from the left
jugular
side to
vein.
the right side.
So close to the skull, and they did not move these catheters. They just moved the
question
catheter
is
in right
that you
atrium.
really need to
Left
get
atrium.
really good position, like since the beginning. But you will stay in the same position. Okay. Full.
Yeah,
Yes,
we.
So I'm
we-
afraid that you
yeah,
have
Yes.
now about 2 minutes, because there is
Okay,
tight
we will
program.
just and look at the eyes. You probably you can appreciate that we are just contralaterally to this previous position.
Yes.
Okay, so we are at the junction between the SVC and the right atrium, and on the opposite contralaterally we have this right superior pulmonary
Yes.
vein. So we will try. Okay, no, yes, exactly. So we are just on the opposite side of the previous points. Remove left atrium, please. And this sweet spot is actually in the PA projection at the level of the ridge of the right atrial appendage. Okay, but on the posterior wall. And here we have 12 grams. Sometimes we have interference with the sheets, long sheets for the extracardiac vagal nerve stimulation, but now we have a very nice position on the eyes. We have 12 grams, and let's go. Ablate here, 30 watts, please.
And here you can also see the right PA, same story as before, right? Right PA, right superior.
Yeah,
And the separation at above the upper limbus, which is the fat.
Drug.
With speeding heart rate, as you can see immediately here.
Yeah, yes,
From
there is additional effect of,
76
Yes.
to
effect of this,
88 immediately.
Predrag.
Yeah.
In that right
Yes.
side position, usually you try to pace phrenic, or you are not afraid.
They have already
Okay, stop.
phrenicus.
Okay.
Okay.
Yeah, we pace the phrenic nerve. Yeah, it's basically green points. Can you show them the map?
Okay.
Okay,
you
and
have
here
idea. Go.
we saw
Perfect.
a very
Okay. Nice.
very
very
fast,
important to test
fast
phrenic.
response,
Before that, yes.
and we had to stop the ablation because we don't want to reach like 100 and 100 beats per minute, because in some patients this can be a complication of the procedure, because
Appropriate tachycardia.
I think
they
we
can feel
discussed this.
very bad, you know. You discussed it. Okay.
So,
Okay,
is
so,
anything else you want to
We
add?
had a lot.
Because we have to move to another
I don't
lab.
know. Okay, you can move. We will finish
conclude
this
the
and
case?
Yeah, it's
Yeah.
pretty much done actually here.
Pascal, can you conclude, or can you
Okay.
add something?
Okay, if you want to say.
No, yes, I mean, the only thing I would say is that we don't know if we have to do biatrial versus single atrium, because I always do biatrial, you always do biatrial, but the only way to know would be to randomize them, because maybe the very first ablation was enough. I think it's not enough, you think it's not enough, but we don't know.
We actually know.
Until
We
was-
actually did that study.
Did you randomize
Yeah,
them?
we are preparing the manuscript. Yeah.
Okay, that's good. So then you know better than me. Because, I mean, I don't know. I always have a question after you have the complete response with the left side or the right side. I always start from the left, whether you need to do more or not. I always do more, but more is not always more, right,
Yeah.
with this.
There is
So your
always
study was a
there-
positive one
Yeah,
with biatrial?
there is always a additional effect of the contralateral side ablation.
Yeah, but the question is whether clinically is necessary.
Clinically, we don't know that
Yes.
because the number of recurrences after CNA is too small. So
Yes.
you would need like a lot of patients to
There
prove
is an
this.
ongoing
So, it's
Belgian
almost
study
impossible.
doing only RA ablation compared to, I don't know if it's just conservative treatment, but they do this kind of study. Oh, pacemaker? Oh, okay.
Yeah.
I don't remember what is the second arm, but it's only right-sided ablation. Okay.
Okay.
Thank you
Guys,
very much
thank
for
you.
a nice demonstration of
Thank you.
this
Okay.
technology and approach, and see you later.
Thank you.
Hey, guys, you can see you. Don't smile.
Okay.
You can smile, but do not say something bad.
Speak Czech.
Hello, good morning. It's Honza and Pavel, and we would like to present you our next live case on cardioneuroablation. And we will try to demonstrate the advantages of a large footprint lattice tip catheter Sphere 9 for this purpose. Next slide, please. So our patient here is a 42-year-old lady. She's a long-distance runner, and she has a history of years of syncopes. She had a positive head-up tilt test. As you see on the table, after half an hour of tilt, she had a hypotension combined with bradycardia and sinus arrest pauses, and she lost her consciousness. Next slide, please. She also had a positive atropine test where she increased her heart rate from 50 to about over 100 beats per minute. And we admitted her here for cardio-neuroablation. Next slide, please. Her echo was normal. There's nothing significant. She's a runner. She's a sporty girl. And next slide, please. This is the last. And as advertised, we are using our Sphere 9 large footprint catheter for mapping the left and right ventricle. This is what we already created for MAPS, and we are going to do the ablations of the ganglias. So,
okay, so thank you, Pavel, for nice case introduction. So as I had the presentation, we will use Sphere 9 catheter and Afra mapping system. Our approach didn't change from previous strategies, so our approach is anatomical, and we use vagal stimulation jugular veins to get an endpoint. So what we have done so far, so maybe you see we have introduced 2 CS catheters, decapular catheter, to both jugular veins. Finally, we spent 4 minutes of X-ray exposure to get to left jugular vein, so it's always more complicated, but finally not so bad. And we can show you on a review precast screen what we got as a response from this vagal stimulation. I start normally on the left side, so you see on precast screen there was a like sinus arrest, and we provoked junctional rhythm. So finally, the pause to recover sinus activity was about 10 seconds. Let's show the pacing from right side, and it was like very similar. So this is what we have started like this. Then we did transeptal puncture, introduced through edgeless sheet Sphere 9 catheter. We also have intracardiac echo, as you see. So this is our approach. We created left atrial anatomy. You see it here on the screen. You can rotate, so it's quite normal anatomy. Then we also created right atrium anatomy, so please add the anatomy of right side. You see it's a little bit enlarged in comparison to left atrium, so you can rotate a little bit. And before complete relaxation, we also added the course of phrenic nerve. So please add our points for visualization of a phrenic course, because this is the area you shouldn't ablate. Yeah, so you see it here. And because we had also time, so we did sinus rhythm activation map. So please, can show us. Okay. No. Can I see? Yeah. Rotate. Okay. So this is somewhere where we should expect sinus node. The patient came with sinus bradycardia. Now we have about 50 beats per minute. So we are ready to start. We are back in left atrium. Of course, you can start on left side, you can start on right side, you can start ablation in superior paraseptal ganglionated plexi region, or you can go to AV node. But in this patient, I'm still not sure if I do finally ablation for AV node, because the clinical symptoms and clinically documented heart rhythm disorders are sinus bradycardia and sinus arrest. So maybe I will finish just ablation for a superior paraseptal ganglionated plexi. This is what I don't know right now. We didn't do any ablation before, so let me, if there is some question, I don't know, if you
Actually,
want to ask
also,
some.
I have a question,
Yep.
Peter.
Yeah.
Maybe I missed it. So she has no any evidence about AFib in the history.
No AFib, no.
She has
There's
no AFib. Okay, perfect. Thank you.
No AFib, yeah. Just the indication is just cardio-neuroablation itself, yeah. So let me go, if I can continue.
Any questions, guys? Here? No questions. Seems to be no questions.
Okay, so I use a lot of the sheet for manipulation. Of course, you can use just the catheter, but for me it's better so I'm used to do the navigation mainly with the sheet and then maybe some discrete movements with the ablation catheter itself. You see that we are nicely touching on anterior aspect of RSPV ostium. There are on the catheter, you see that with these electrodes, which are highlighted like a white, that we have a good contact. Do we have also Pruka screen if you want to see some electrograms in this area? Okay. Can we do it in 200 sweep speed? And I think this is a typical location where we can start here. We also tested phrenic nerve here from left side before relaxation, and we didn't capture phrenic nerve. So I think that even that the course of phrenic nerve here is like close, but we weren't able to capture it. So I think this is safe area for ablation. Let me check also on eyes if we have good contact here. You can have maybe eyes view for a while. Can we add? Okay. Nice. Yeah, so we have good contact here visible. Okay, so let's start ablation. Before I start ablation, so let's go with sweep speed maybe for 50 or 25, because I want to show you, hopefully, what is the response here after first application. I'm not sure, but hopefully we'll get good response from this area. So you have it, okay? So now we have 57 beats per minute, and we do the ablation with RF lesion, 5 seconds. Yeah, so can I go? Let's go. Okay, so we will see. Yeah, there is a definitely response.
It's like
yeah, you have 80 beats per minute right now. Okay, so that's good. We normally do not just one application here, because if like it's visible here, the heart rate is decreasing again. So I enlarge a little bit the lesion, not in the same spot, but I go a little bit lower and then a little bit up. Let's go here for the second ablation. Maybe let's go a little bit closer here.
So do you want to get a more septal maybe? Or I don't know, maybe not.
It's okay here. Can you rotate to the right, the main screen?
Oh, you are
Okay,
more
that's good.
septal. Yeah.
So let's
The danger.
see it here. So 5-second application again. Okay. So now we have maybe better response, and let's finish maybe the third application somewhere here. Now we have 80. Okay, so let's do one more here. Moment. Try to get good contact. Let's go here.
Now the effect is more permanent. Okay, it's still like
So we have
300,
nice temperatures, you see,
300
on the catheter.
milliseconds.
So now we have 80 beats per minute. So maybe it's persistent right now. If you want to test maybe what is the reaction finally, if we do vagal stimulation right now, so maybe we are ready. So I normally do ablation here, then in the left side I go for inferior paraseptal ganglionated plexi, and then I test the reactivity. But maybe we can show it right now. So
Also,
we are
the
ready to
vagal
pay.
stimulation performed was from right side, right?
Yeah, so we did both sides, from left
Okay.
side and also from right
And
side.
it was
So
the
we
same
can,
effect, or
yeah, very the same effect.
Okay.
Like, yeah, we saw mainly the sinus arrest with some junctional beats. Yeah. Okay, so now we have 80 beats per minute. It's maybe more persistent than after one application. Now we are ready to do vagal stimulation from left side. So let's do it right now. Please go. You see, if you measure PP interval, maybe there is no sinus reactivity. So we abolished the effect on sinus. And there is an AV block. So now we have to discuss if it's really reasonable to do it also in inferior paraseptal ganglionated plexi. I know there are some connections, there are some nests, like NET. This is not just a one location for sinus node, one location for AV node. So maybe I do one application on the inferior. So can we just maybe from right side as well?
I think if she's a sporty, she may be
Yeah, she's-
very sensitive to increase in heart rate. We had one patient who complained that he had a plus 10 beat per minute, and he was complaining, although his
No tachycardia.
performance was good, but he was complaining that he cannot bear this. Maybe, I don't know, if, the more you do,
Yeah.
the more you can then
Of course, yeah. So this
overablate.
is what I'm thinking. If to do another lesion also on AV node, but we normally
I
do
would
it.
probably do
so-
just as a node area.
You mean for a sinus node
Yeah.
only? It's possible, of course. Yeah. So maybe let's go. Let's space also from right side. Yeah, there is a like dominant activity from, and if you do it from right side, this is spacing from right jugular vein, and there is AV block as well, and there is no PP interval prolongation. So finally we are done. I don't know if we should continue like, but okay, let's go to right side because I think.
But she never had AV block documented.
No, it's not documented, never. So let's go to left side, right side. Let's go back. Okay. Okay, now we are in SVC. You see how quickly I'm there. I again use my sheet. Can I have a view from left lateral, something like this? And please cancel for me the left atrium anatomy.
Actually, also it's a good point with Sphere 9, with Affera system, if we really need to get this sandwich.
Yep. So you see how close we. So we are surely far away from phrenic nerve. Can you rotate left a little bit more? More. So I don't want to do the ablation somewhere here. If I do it here, it's complete sandwich from the previous location. I normally start a little bit high, but I'm not sure if I do a lot of ablations here. During atropine, the direction was like from 50 to 100.
From 50 to 105, so twice.
Okay.
I'm still
So what-
78, and we started
Yeah,
below
so-
60.
Yeah, I think it's so. So can we have sleep speed a little bit like 200 or 100 at least? Okay, so we should be far away from sinus node. And I need to push a lot to cut it because, it's really big. It's 9 millimeter. So I'm trying to get good contact and push catheter close to left atrium anatomy more subtly. Yeah? Okay, so I start normally a little bit higher than the previous ablation. And I can continue here.
So you
what
are
we have
deflecting just the catheter or you have
I'm using the sheet.
Agilis?
Yeah, I use Agilis. Of course, you can do the catheter
No,
as
you
well.
have not
but
too
I
much
think
adjust because they're not indicating the bypass.
Yeah. So can you rotate just that we are really sitting like to a septum? Yeah, you see that we are touching really septal part. Okay, let's go here. Ablation? 5 seconds. So we have 76 right now. Let's go ablation. Okay, so let's see the response.
It's a decrease.
It's again increasing a little bit, it's not too much. It's 80. I go down a little bit for bilateral ablation. It's 80. It's not increasing too much right now.
Nothing.
Let's go here. I don't want to over ablate here. Okay. 85. I would be okay maybe with this result right now. So maybe we can vote. I don't know if how many people are sitting in the audience. So if you want to vote or if you have some suggestions what to do, but maybe for this patient I would stop it here.
Yes.
Yeah. There is a AV block.
I think given the history and the age, I would probably also be more conservative in this case.
Yeah.
Anybody else has? They are more
Actually,
aggressive.
you can always repeat it, right?
More, yeah, exactly.
Yeah, of
Well, you
course,
can
yeah.
always expand if there is a recurrence of problems. So, Sebastian, what would you do? You are the expert here with large experience.
You should discuss with the patient how is her approach at the beginning. Yeah, but at the beginning of the procedure, you should explain it. But of course, the sinus tachycardia in the marathon runner could be a problem. Yeah, and even in resting position. But of course, we can also assess the vagal stimulation right now is persistent or not, and we can complete this. So. You have by the left superior paraseptal application, you have almost complete denervation of AV nodes, so it's enough. But of course, if you have a patient with only sinus assisted, you never know whether the next syncope will be with AV blocks.
So Honzo, do you want to? Thank you so much. Do you want to conclude?
Yeah, so I think that you see that with this catheter, the application itself is very, very short. It's, I would say, safe. You need to know that the footprint of the catheter is bigger, so you'll be far away from phrenic nerve mainly, and also some other structures. So if we do maybe ablation on pyramid region, we are trying to be very, very conservative, not to go inside the coronary sinus. Maybe you remember from my presentation, like 1 hour ago, there was still one patient with AV block provocation after ablation. And this was at the beginning of our experience, and we didn't want to go to a coronary sinus itself, to the ostium. Finally, we have some experience. We did, I think, 2 or 3 patients with CS ablation, but you need to push the catheter a lot of like posterior, superior to avoid anterior structures. So this is what I don't want to do normally, but sometimes you have to do, mainly if the clinical symptoms are coming from AV block. So so we did finally 5 applications. So it's 25 seconds of ablation time, and I think we are done. Yeah.
And
Thanks
still 76 what? 76 beat per minute, right? So thank you so much. Okay, it was excellent example. Thank you so much.
Thank you.
So we move to the last live case, and then we have one pre-recorded case from Sebastian. So,
no, tak tam pak, takže do toho to bude
Dane,
muset vždycky...
Dane,
už jsme tady.
You are already live.
Okay,
Když tak moc nemluvte teďko, jo, aby tady nebylo 10 lidí najednou.
But you can speak.
Ladies and gentlemen, welcome back to EPLab ICAM. My name is Peter Štiavnický, and together with Professor Vichterle, we will focus on repeated cardioneural ablation in this live case. Next slide. We have a man, 39 years old, with medical history of recurrent cardioinhibitory syncope since April 2023, 5 episodes all addressed. And at that time, the patient was implanted by Reveal, and one syncopal episode was correlated with 14-second asystole followed by sinus bradycardia. And at that time, the patient was indicated to the first cardio-neural ablation performed in November 2023 with satisfactory denervation of sinoatrial and complete denervation of AV node after procedure. The comorbidities, arterial hypertension, dyslipidemia, and normal echocardiography findings. Next slide. And now I will show you a few slides demonstrating what we did during first procedure. Standardly, we use bilateral extracardiac vagus nerve stimulation, and you see a floral and the position of both decapolar catheter within right and left jugular vein, and the baseline parameters before the first procedure, when you can see maximum sinus arrest of up to 9 seconds and the maximum AV block 9 to 6 seconds. Next slide. And this is a map of a right and left atria focusing on the ablation of superior paraseptal ganglionated plexus. On the left map, which is right atrium, you see an ablation line in a posteroseptal quadrant in a junction between a superior vena cava and a right atrium. And in a right map, you see a left atrium and a contralateral cluster of ablation setting to the ablation line of right atrium. Next slide. And this is all structures, right and left atria and the coronary sinus, focusing on inferior paraseptal ganglionated plexus, which is pyramid-shaped space bordered by right, left atrium, and coronary sinus, and a cluster of radio frequency ablation lesions. I would like to highlight that many points put in a coronary sinus don't represent individual ablation lesions, but dragging strategy. Next slide. Current presentation, the patient was asymptomatic until April 2025 when recurrent pre-syncope episode occurred, and implanted recorder documented sinus arrest, and you see a list of documented events where you can see many sinus arrests up to duration of 15 seconds and a strip of one documented episode. Next slide. In this slide, you can see comparison of atropine test before first procedure and atropine test performed yesterday. Before first procedure 2 years ago, the patient accelerated from 53 to 100 beats per minute, which is about 100%. And the reaction to atropine performed yesterday was weaker, but significant. And the patient was indicated to repeated cardio-neural ablation. Next slide. And what is scheduled in this procedure? We will do ablation using Thermocool SmartTouch catheter. The procedure will be 3D navigated by CARTO and facilitated by ICE. Also during this procedure, you will see the utility of ICE in real-time imaging also during cardio-neural ablation. The strategy will be biatrial, and the procedure will be guided by extracardiac vagal nerve stimulation. Paschon's neurostimulation is well established, but we will also discuss and present alternatives. And more about strategy in this case will be presented by Professor Wichterle.
All right, thank you. Maybe we will show first the left and right atrial mapping. Can we see the live CARTO? Oh, okay. All right, so first I will briefly mention all the anatomical landmarks we use for targeting the GPs. You are looking at right atrium. You see the activation remap of right atrium that identify the sinus node superiorly. I can show this by my catheter here. And subsequently, we have seen some shift of the endocardial breakthrough of sinus node. So later during the mapping procedure, we identified the earliest breakthrough here in this yellow spot. So this is just to remind that the endocardial breakthrough of sinus node is pretty variable and can change during the procedure. But definitely it is located anterior to phrenic and it shouldn't interfere with our ablation lesions. Then you see that there is a small map anterior indicating the separate mapping of right appendage. And this blue point superior, it is our landmark indicating the ridge between right appendage and superior vena cava. And at this level, but most posteriorly, please PA, pure PA, this is our sweet spot. So usually we do kind of horizontal line, sometimes also like initial part of intercaval line to denervate the superior paraseptal GP. And when we transfer this or copy this point to the left atrium, and please show us the left atrium only, and from AP you see that it sits superiorly, rather superiorly. It's a little bit unusual anatomy. It's rather superiorly in anterior vestibule of right superior vein. But it's all right for ablation, and we will re-ablate this GP bilaterally. Now, please focus to inferior GP. Maybe, please, I will try to go to left atrium again from AP, just to re-navigate to left atrium. I'm inside, and now please PA and a little bit lift up, and I will go to this pyramidal space. Now the catheter is sitting somewhere there. You can appreciate the visualization on eyes, and you see that we are sitting at the sweet spot for denervation, or now re-denervation of inferior paraseptal GP. And when we include also the mapping of CS and mapping right atrium, you see all these like dark violet points or dark blue points. All these identify the base or different aspects of this pyramidal space, and all these might be or should be re-ablated. So I think this is hopefully everything concerning the anatomy for GP ablation. And what was surprising, even if the patient responded to atropine, prior to first procedure, there was a huge response, like acceleration of sinus node post-atropine to twofold level. Now the response was a little bit weaker. It was only plus 38%. But we still believe that there is some parasympathetic reserve to be ablated. But what is strange, we maybe see the fluoroscopic images of maybe first the angiography, because we struggled.
Je to tam.
We struggled with access to the left jugular. Yes, this is angiography of left. You see there is some kind of abnormality, so there were difficulties in positioning of the decapolar catheter in right jugular. Now, please show us the position of both catheters. This is this last snapshot. So this was the final position. And when we paced either with Passion neurostimulator or with old MicroPace, EPS 320, or with the new platform of OneStim, there was almost no response. So this is something what was not compatible with this result of atropine testing. There was only tiny slowing of sinus rate, maximum by, let's say, 10 or 15 beats per minute. And there was, once we have seen one non-conducted atrial beat, but during the subsequent maneuvers, there were, and we tested multiple positions from right side, left side, but there was only like slight prolongation of AV, nothing else. So according to current extracardiac vagus nerve stimulation, there is almost complete denervation of both nodes, and it is compatible with electrophysiology, because we did sinus node recovery time, we did Wenckebach point and AV nodal refractoriness at baseline today, and the values were almost the same like at the end of the original or index procedure. So there is only a little to be denervated, and we will try to do this. We have almost no guide because of these weak responses to right and left extracardiac vagus nerve stimulation. What we can do at the end is just to give again atropine to see that there is no response to atropine. But we will do this. We will do this only at the end of the procedure. Okay. So let's start. Do you have any questions regarding this?
Dan, Sebastian speaking. Can I have a question about your repositioning or vagal nerve stimulation catheter down and validation by ultrasonography to see exactly that you are at the vagal nerve? But it's of course uncommon to have such response.
We have no. I know that this is possible, but we have no dedicated sonographer which would help us with this.
You can also use
we rely on
tip of the cutter and the C1 and C4 just to spread out the current to catch the nerve, if it's there. If you
I have no. No, I have no experience with this.
From the ring 1 and 4.
But we tested. In my experience, if you test multiple sites, it usually, and it has happened. It can be even worse, because after multiple attempts for vagal stimulation, there is like weakening of the response. So after multiple testing, we end up with complete non-responsiveness, and we should have waited for some kind of recovery. So this is maximum what can be achieved, and I think there were some weak responses, and we will rely on this. We are not able to do any more, and we know that the catheter position, fluoroscopic catheter position, is exactly the same like during the index procedure, and at that time we had huge responses of both sinus and AV nodes. So I'm pretty sure that we are in contact with vagus, but that is like the denervation is nicely preserved since the original procedure. All right, so maybe Peter will continue with ablating, and because we are in left atrium, we will start ablating there, not to switch between right and left too much, and we may start ablating at the pyramidal space. We will start at the base. The only option is just to re-ablate and a little bit extend all these lesions, and at the end we will retest with atropine. All right, so you may again. So look at the Carto screen. We are just in the middle of the pyramid, a little bit closer to the apex, and let's ablate here. There is no interference with other catheters, so we may ablate. And we may rely on ablation index. We usually, at atrial side, we go up to 450. When we are in coronary sinus, we go up to 350. And that's it. And we probably do 3 lesions here. At the bottom, at the very bottom of left atrium.
Okay, stop. 400.
450.
450. Okay, continue.
Ablate. According to eyes now, we are a little bit distant from the apex of this pyramidal space. So this is another position. And then we will go more posteriorly towards the right ostium of right inferior vein. But plus minus, we try to align with these original tags, these blue or dark violet. All right, it's too much. It should be closer. Okay. I think it is all right here. Yeah, ablate here. So this is reablation of our standard region, and because there is no problem, likely no problem with AV node, so I think it is enough. There is no need to extend. But what we do definitely is to ablation of superior left GP, because this was not ablated during the index procedure, because after superior and inferior paraseptal ablation, there was non-responsiveness from the original huge responses. So in such a cases, we omit this ablation. Now we go for right atrium. So we will ablate the pyramidal space. Again, you can see on ice, maybe a little bit higher. We may go up to this violet point, just to be at the apex of the pyramid. Now again, here,
Peter.
nicely.
Actually, how many lesions
Continue.
you plan here in this region, in the pyramid space?
Usually we give nine standard lesions. Three from bottom of left atrium, 3 from this region, we are doing just now, and 3 from the posterior aspect of proximal coronary sinus. So nine. And again, when we are ablating superior GP, we give usually, maybe now we give more just to. But normally we give 4 lesions. So
Continue.
our standard number of lesions is 17.
Well, actually, this is
sorry,
the question was about
eight plus
this patient, okay, because it's very unusual. It's a little bit unusual.
Yeah.
Like failure.
We should ablate more, because we have it can't be nicely guided by extracardiac vagus stimulation if there is no baseline responses. So we ablate more, and definitely we will ablate also the sites that were omitted during the index procedure because of nice procedural endpoint at that time. So
eyes, you have a very nice effect of the ablation as well.
Yeah. You mean whitening of this pyramidal space?
Absolutely.
Oops.
Yeah.
Or dislodgement. Yeah. Okay, we may continue. There is no need to be so precise, because we are ablating all the time the same region.
There are a couple of lesions you have like very nice impedance decrease and higher temperature.
Now we go to the coronary sinus. We are already inside, and pull back a little bit to the. Just to finalize this.
Tilt down and left side. More left. Thank you. Okay.
And usually now we contact force reading is not reliable, because it is like interference with the decoupler catheter inside the coronary sinus. So we reduce the power to 25 watts, and we will ablate, let's say, 30 seconds, because it's out. Wait. So we can't, again here, we can't rely on ablation index. Otherwise, we should. The only solution would be to remove the CS catheter. Now it looks like the force is 24, but this is not.
CS, we are starting
but
10
this is not real. This is not real.
Okay, 20 seconds. Continue.
I will try to visualize on ice. Now you see on ice as well. You see the bubbles coming from the proximal CS.
Ano. Continue.
All right, and maybe this will be the last delivery to the inferior paraseptal GP. Ablate. And now, because we are
and now
in the right atrium, we will go to superior in right atrium, and we will finish in superior in left atrium. Yes.
Okay. 20. Stop. Okay. Right atrium PA.
Right atrium only. And we will start in this sweet spot. but we will not create the horizontal line because it was done during the index procedure. We will go kind of proximal part of intercable line because it is effective as well, a blade. Maybe three, four deliveries. It's not so fast like with Sphere 9, but because of, we have, let's say, 17, normally we have 17 deliveries, each duration roughly half a minute, so it's like 8 minutes of radio frequency time. With Sphere 9, you have like totally 1 minute, so you may save like maybe 7 minutes of radio, 7 minutes of the procedural time. Of course, there might be benefits that if it is proven that is effective from right side only, you may avoid like transeptal and ablating in the right atrium, but definitely not in all patients. In some of them, especially in males with sinus nodal disorder, but definitely right-sided ablation is not enough. For example, in female with AV nodal phenotype, because in all of them, the superior left GP should be ablated, and when the transeptal is already done, it's useful to ablate like all the GPs like in sandwich-like fashion.
Okay.
Ten bod nebyl nějak vidět, to někomu zapadlo, ablate.
Okay,
Arvi, jsme tam, zahajme s ní trošku, jsme tam opravdu, nejsme někde jinde, ne, OK. Když tak tam, OK.
Tak ošejvuj to.
So we should have last presentation this pre-recorded case. If you want to come back later, or if you will close this case now, would you like to?
If possible, we would like to at least to do some close-up very briefly, if possible. If not possible, no problem.
No, I mean, we can come back after, let's say, 15 minutes after presentation of Sebastian, if you prefer. That would be better.
Yeah, no problem. No problem. Absolutely no problem. So, we may wait.
Okay.
But,
so Sebastian will have now presentation.
Thank you.
I'm sorry we are a bit delayed against the program, but we skipped one presentation at the end, which was about to be, which is not even now in the program, but it was there before, and we moved this Matthias Dwichaver talk at the beginning, and then we allow time for each live case a longer time and for discussion. So we are a bit delayed, but I don't think it's a problem.
I will speed up the presentation.
Okay,
it will be very, very fast. Cardioneuroablation with 2 times speed. So, but the procedure still takes 40 minutes.
Fast and
and facilitated very fast. So 3 catheters approach from the groin, 2 short, introduce 1 prolonged. For the access to the direct access by leader to the internal jugular vein. You see, I'm going very strictly, and the X-ray is in the head area, and you can facilitate that we are directly going to the internal jugular vein. So for the right side, it's easy. But it's nice to start from the thinking about you have a straight leader, and you can also go through the sheet to this area, very safety. Our setting is 45. We use a Paschon stimulator, and you leave this here, and you have access for the ablation catheter that we use for the validation of right-sided only. If we have a problem with right side, of course, go to the left-sided, but unipolar is enough. Unilateral is enough for us to validate. This is okay. This is wrong. This is Maximus branch. Don't go this way. You had rather to start on the lateral side and then go to the medial side of the head. If you have a head straight, you can be almost close to the ocular And the basic EP study, you advance the secondary catheter to the CS, and then I will show you some tricks about the validation of the sinus activity and AV node activity that we use. So this is, of course, the sinus node refractory time and corrected time for 30 seconds, but still you can see prolongation of PR, which is okay. This is still back, and there is a huge validation of the sinus node. 4 beats is enough to validate this, as our study showed. Of course, you have a normal corrected sinus node refractory time, but still the norms not exist because you can have some 2 seconds asystole on corrected time, and you can decrease this. But we're using 10 seconds, 60 beats per minute validation, and then you can see our shortening the mixed echoes. So you assess both the sinus node and AV node, and then you can prove by, this is not direct, that the tears are coming because you capture the nerve, and there's a retrograde connection. So you open the space to see the tears, and anesthesiologists have something to do with you. So if you validate this, you can proof of capture of that, and we completed the basic study. We have a retrograde conduction, very slow, with maybe retrograde split of slow and fast pathway, but still we have start, and then you can assess, of course, the His and not splitting the His during incremental attack pacing. Not only the basic His is important, but also the His splitting, which is not here. We are pacing usually from the proximal coronary sinus, many things, but still there is no HV prolongation or splitting. Transeptal puncture using the ablation catheter in the His position, and we are there. You can also store the position of the vagal nerve stimulation for the future, and then we start immediately with general anesthesia, short-lasting paralyzation drugs with an anesthesiologist. So this is a teamwork and collaboration. This is our wolf mountains on the wall. So we are working in the mountains and wolf area. And this is the beginning of the procedure. You have a 45 and start immediately, not to lose the time, because if you know from the AFib anatomy patients, you know how it looks like. So left superior, we started because the patient is, I didn't mention that the patient is with syncope and AV block, so we start from the left superior just to have another place of blocking left-sided vagal nerve activity. And usually we started from the left side because you can see the vagal reflexes. It's not the case in this case. You have a normal sinus, no prolongation of PR, and during the sinus rhythm, and no prolongation and shortening during the 600 millisecond pacing from the CS. You will see that we can validate continuously the impact of each application, not only from vagus nerve, but also from the pacing. So we move to the mitral annulus area and the pyramid of Wichterle, as you mentioned 2 years ago, and we proceed with the application. You see there is a prolongation of PR still there, and the next will be reverse G-wave-like maneuver, and then we're more in pyramid, and then still prolongation, PR, and then we will apply the energy. Let's start, and you can see the testing of the continuously by just stimulating proximal coronary sinus. This is not a midnight, this is the noon. We started about 11:40. See, there is no prolongation of PR. So we are lucky that we can measure this, and it usually you have to go down to the 150, 180, but still there is a continuous. There is a junctional rate first ever. Don't worry about this if you have a good, but you have automaticity of the AV node. This is another good spot. If we have a single automaticity that never been seen before, it could mean that you are in the good spot making this like Wichterle triangle, and you have a junctional retrograde conduction, which improved a little bit, and now you can see that this is short PR interval stimulus to QRS or whatever, but this is a meaning of that you are touching the automaticity of the AV node, which confers that the shortening of conduction. So we proceed with additional bonus application for 50, 60 seconds in the such good response for the AV node. I should remind you that the patient has AV block and syncope, vasovagal syncope, and normal heart. And then we proceed to the right superior pulmonary vein. And then we validate the phrenic nerve. You can also pace with the general anesthesia full relaxation of the muscles, but as a TOF control or as a just single 3 beats pacing, you can validate the position of the phrenic nerve continuously. So we assess that it's crucial to start in this point. Of course, you see how is the right superior pulmonary vein. You collect the data from Victorle, from Brussels, from Belgium group, and you adjust your procedure to get this spot. And now you can see it's not a 60 bits, 40 is 85. Immediately, if you catch it, you call it the green point of interest. You can see that there is also validation of this, and there is no huge variability of after completing the pacing from the CS. So you can still another issue that the patient is denervated. This is some AV block during pacing, so no worries. And now we can continue. It's 85 beats per minute. And then we proceed to the right side. This is a return to the right side, assessment of the phrenic nerve. And the P wave, we assess also whether a P wave is flat or getting more positive. And then after validation of phrenic nerve, we start with the additional bolus application for the superior right paraseptal GP. And now we don't want to be in the front of P wave at least maybe 10 milliseconds, but not longer. And now we're starting a bonus application from the right side. And then we are not entering anymore the CS area. We are just wanting to low inferior. We do from the position of posterior to the CS ostium for the denervation of AV node. So this is not capturing, yeah. So we don't start in this area, which if you don't touch capture the tissue. So this is another pace and maneuver to speed up. Now we capture 3 at least, so we start this area and at the level of vena cava superior and go down. And still there is 80 beats per minute in this lady. And now we completed, it's almost half an hour till now. And now we are going to recheck his position and then go down to the CS os and then proceed to the posterior part of CS off, or rather the internal jugular, interior part of the septum. And you see by using the electroanatomical mapping, you can find a green ball from the left side, and you have almost touched the same as from the right side. This is the marker of that we are very close and touching the pyramid space. You will see the movement of the 3D maps to show this, that we are almost in the, like here, we are almost touching the same area, and we are almost at the same spot covering the area. And this is we almost done, so it's bonus GA relaxation, so you speed up the procedure by having the collaboration with the anesthesiologist. The rhythm is 65, so it decreased. So now we are starting again with the wire and proceed safely here and start the vagal nest stimulation from the right side. It's appropriate positioning of the catheter, and then we are, you can see there is no, and we proceed with mixture, so we paste also to see whether we have a AV block. You can also combine with Wafit, and you see we validate the tears, and usually after 2 pacing you get tears, so the patient is crying to get healthy. And then we move to the left side, which is much more difficult for all beginners. I will advise to use it many tricks. This is wrong way, not be medial. This is wrong way. This is very smoothly by catheter, so you will feel it. And now I decided to do by wire. It's not. You can use your fellow. It's sometimes much efficient if you use fellow or the second hand. And this is you can also do it from subclavian, but you just need the patience to get there. And you see there is nothing, and then again, and now you are there. And there is sometimes 2 or 3 veins that is called internal. It is very medial. I was thinking that it's not possible to go there, but still we have been crossing. You have to move down to get the branch, and now you can check by lateral position. Anesthesiologist confirm that you are fine, and you are pacing from the left side. I should just make slow speed, and you assess that here, and you're almost done. And can we a little bit make it? Figure 8. It's almost 40 minutes from skin to skin, and door to door will be 1 hour, especially for the Petra. And almost the last. I was given this toy from the first kid parents for cardioneuroablation, so it's nice. Can we make a noise louder? I cannot hear it. No, make it louder. Please.
So, everybody, hello for Fast and Curious Cardioneuroablation live case. Thank you very much for your attention and your suggestion for the future treatment of the patients. Thank you very much. Dziękujemy bardzo.
Thank you very much.
Thank you very much. Any question or comment? I think we saw today different strategies, different approaches. This is a simplified approach. It can be done very quickly. We usually don't have so many patients like you have, but you are a much bigger country and you are concentrating patients. So then there is need to speed up. Well, we can play a little more with this.
It's interesting to comment that even in US, the CNA is penetrating now as a off-label procedure, but it's still going more and more centers doing that. So it's probably good influence from here, from you and Pepa and Professor Pashan.
Thank you very much.
Thank you.
Last but not least, we should have one talk at the end by Dr. Goethe, who is now based in Calgary. I used to be in Germany, I assume. Oh, Netherlands. Sorry, Netherlands. I mixed.
But it's like American, doesn't matter.
Yeah, it doesn't
Germany,
matter. I'm like Trump. You can mix up names and you can mix up countries.
National.
No. So initially we planned to try to have such procedure, but finally, because of some logistical reasons, we decided
we didn't proceed because we tried to get live case very, aggressively, but the logistics was not optimal.
Okay, please.
Well, thank you for this introduction, and it is a pleasure as an imaging cardiologist to be part of this outstanding EP conference. And I feel honored that you have a full session dedicated to MR and EP. So thank you very much. And the talk is about the promise or the effects of MRI-guided procedures in AP space. Or in other words, how MR is transforming the cardiac interventions. And basically, this is a brief introduction for you all electrophysiologists, how your new workspace will look like soon. So this is an MR suite where we performed in Amsterdam EP procedures. So this is a complete transformation of the MR facility from a dedicated diagnostic imaging modality into a interventional space. These are my disclosures. Why would we do MR-guided interventions anyways? So there are an increasing number of patients. You have illustrated the complexity of cases, illustrated by the live cases last Sunday. Sometimes this is associated with prolonged procedures, and also we strive to minimal invasive procedures in general. There are targets for improvement. We strive for a radiation-free environment. We want to have faster and more precise procedures and fewer process steps to make it more simple. And we, of course, also try to reduce the redo rate. And if possible, we try to avoid the need of contrast agents. Cardiac MR offers you a radiation-free workspace, highly detailed visualization of tissue and structures. The unique capabilities of MR are the tissue characterization capabilities. There's no other image modality that offers you tissue characterization at the level of MR is able to offer you. And it also allows you to do real-time imaging and even real-time temperature mapping of tissue, which is relevant for ablating patients. So the idea is that by better clinical that we can achieve better clinical outcome by better visualization, and makes the EP procedure more simple. Critical factors for a predictable and successful outcome are the selection of eligible candidates, the pre-procedural workup, but also the accurate navigation and positioning of instruments, which is sometimes quite challenging, but I noticed during the live cases. Then, once you have positioned your instruments into position, you strive to a targeted and precise and also controlled therapy delivery. And finally, you need a kind of proper sign-off of your procedure. And finally, and ultimately, you need meaningful clinical data. I will only focus today, for the sake of time, on the accurate navigation and positioning of instruments, because that's one of the critical factors that determines the outcome. If you ablate at the wrong location, then the outcome is not what you expect from it. And how can you manage this? And the second thing is, how can you deliver targeted, precise, and controlled therapy? Basically, we translate this situation you will recognize. So in the fluoroscopy, advanced catheters, but you do not see the surrounding structures. So that requires a lot of human interface, the image created in the head of the electrophysiologist to understand where you are and how you navigate your instruments. And of course, you can add the electrical anatomical maps for navigation purposes and also to evaluate what you have done. But it is a derivative of the modification of tissue, which is basically an ablation procedure. You change the tissue property with the intent to modify the electrical behavior. And the electrical signals are a derivative of the modified tissue. And MR offers you to visualize the surrounding structures, shown like this, with this quality. It gives you information about lesions created. This is an isthmus ablation after Flutter case. In a Flutter case, you can visualize in 3D the rings created surrounding the pulmonary veins. And of course, with post-processing, you can also identify gaps in lesions you have created or gaps in lines you intend to create. So MR has a lot of things to offer to add to the conventional EP space. How do we do this? How do we navigate catheters using MR? Well, there's this specific catheter, an MR-compatible catheter, so the material needs to be MR-compatible, non-ferromagnetic, but on top of that, there are two coils built in the tip of the catheter. And these coils are directly connected to the scanner, and because there's a direct connection between the coils and the scanner, the position of the catheter is known by the scanner. And there's a very accurate way of locating the scanner in space and in the heart. We can use these coils to visualize the catheter. So this is a conventional strategy, and we call this active catheter imaging, where the coils give this bright signal. So you can observe two bright dots reflecting the position of the coils in the catheter and in space. And this is how we started doing this. So we built this program starting 2020. But this is actually the first patient we did, and we did a Flutter case. Nowadays, we have a more advanced navigation system, which is called NorthStar. And based on the signals coming from these coils, there's a rendered catheter projected in a 3D shell. And there's the static shell you're familiar with, but on top of that, we can also run real-time MR sequences that allows you to integrate the position of the catheter and the heart beating, the beating heart and the displacing heart due to the breath holds on top of the static shell. So this gives you a better appreciation where you are with your catheters. So from an imaging perspective, I think that the accuracy of navigation is one of the determinants of the outcome of the procedure. This is how we do this. At the beginning of the procedure, so the patient is positioned in a magnet, we acquire a 3D MRA without the need for gadolinium, so there's no contrast involved. And using this data set, which is acquired within 5 minutes, we can create a 3D shell, and this shell can be uploaded in this navigation system shown over here. So in 10 minutes, and in the meantime, the interventionalist, the electrophysiologist, is flushing catheters. As imagers, we provide the workspace for the electrophysiologist, a 3-dimensional shell, and we can also add additional information to this. Then we can, then the catheters can be advanced, shown over here, and once the catheter enters the center of the field of view, these become rendered catheters like you used to work with. The catheter tracking is with 4 to 10 frames per second, and the spatial accuracy is really high. It's 1 to 3 millimeters in space. What we do is we run only a tracking sequence, so that only visualize the location of the catheter. So that means that the scanner is quiet. Sometimes there's the concern from the interventionalist that the scanner makes a lot of noise, but if you only run the tracking sequence, it's really quiet and it is comfortable, so you do not need a lead apron. On top of that, we use burst scanning, so interrupted fast scanning that allows us to look at the EKG signals, and I'll come to that later. But it gives you unaffected EKG signals while the patient is in a magnet. And then you can navigate, and on top of that, you can integrate pre-acquired 3D LTE images, like this case, and you can integrate this with the navigation system. Sometimes there's the concern in the EP community, okay, we talk about ventricular ablation, that's the holy grail, that's the added value for MR. What about ICDs? Well, this is a patient with an ICD. And you can observe that you have nice, clean images. If you look at the right side, you can observe the lead, shown over here. There it is. But it does not affect the image quality. So it's not a concern. And of course, if you strive to do MR-guided ventricular ablations, 50% of the patients will have an ICD. So that's not a limitation. And finally, if you process this data, so this is a data set acquired prior to the interventional procedure, you can integrate this with this navigation system. So within 10 minutes, you can offer the electrophysiologist a 3D workspace, the accurate position of the catheters, and the tissue substrate. There are differences between the different strategies how to visualize the catheters, but my expectation is that active tracking, based on these building coils and just visualizing the rendered catheters, will be the standard procedure. We tested this and we went through different processes, and the first step was we created a bench or test bay where we used an explanted beating big heart with a right to left circulation. So it's not a Langendorf perfused heart, it is a normally functioning heart hooked up to a heart-lung machine, and we made the whole setup MR compatible. So this is the beating heart. And finally, we put this setup in the magnet. So there's the beating heart. And we did this using a Philips 3T scanner because that was a research scanner available, and this was during COVID. we were not able to do patients. So that's why we started doing this. And what you can observe here is a real-time image of a free beating heart, free beating in space, where there's no surrounding body. And the heart has its own electrical activation. And we use this model to test devices, to test accuracy of navigation. But on top of that, we were also able to ablate these hearts, as shown over here. So there's the manipulation of the catheter, and we ablated the ventricle, shown over here, and we used also NorthStar for this purpose. And the reason why we did this is that we can then relate the visual data provided by MR, you could call this a virtual histology, to the actual histology, because we can slice up the heart and we can analyze the lesions created. And the purpose of this experiment is to come up with distinct histological characteristics of an acute ablation lesion and find the distinct features in the image data that tell us if it is a durable or temporal lesion. Because that is one of the holy grails. If you are able to identify this is a durable lesion, or this is a lesion which is currently isolating and there's no electrical activation, but it is consisting of temporal components that resolve over time, then there will be a recurrence of arrhythmias. So we dived into this and we tried to sort out with AI what are the distinct features in image data that tells us discriminate durable versus temporal lesions. Then last year we did a first PVC ablation procedure. These are the characteristics of the patient, PVCs. We used a Siemens 1.5 scanner. We used a NorthStar EP platform from Immucor and the Adventus ablation system. We also used a 12-lead EKG recording system, which is MRI compatible from Myrtle. And we used also an experimental MRI conditional external defibrillator, because that's another challenge. If you run into issues, you need to be able to defibrillate the patient, but you do not want to ruin your setup. So this is a defibrillator which allows you to defibrillate the patient while the patient is in a magnet, and basically you can continue with your procedure. And we use the in vivo hemodynamic monitoring system. This is how it went. So this was the 3D shell we created. Then we did mapping in the RVOT initially, so you can map and pace while the patient is in the scanner. We did the activation map, and finally we did an ablation in this particular area, but then there was still recurrence of PVCs, and finally the electrophysiologist decided to advance the catheter via the aorta into the LVOT, which is shown over here, and this is the catheter in the short, the transversal image plane, and this is a sagittal plane where you can also observe the catheter, shown here as well. And finally, we did an ablation in the left coronary cusp, and the patient was cured from his arrhythmia. Just to demonstrate that you can safely advance catheters into the RVOT and the LVOT. Finally, we did some advanced imaging, and these are just examples how we approach this. So we pioneer new imaging strategies that allow us to visualize the ablation lesion created, and one of the objectives is to try to visualize these lesions without the need for gadolinium. I foresee that finally it will become an iterative process where you ablate, you visualize, you decide, and then you re-ablate if necessary. And you cannot do this if you need contrast, because once you have administered contrast, you cannot repeat your imaging. So one of the targets, one of the research focuses my team works on is to come up with imaging strategies that are fast, but also independent of contrast agents, and that allows you, again, to discriminate between temporal and durable lesions. These are a couple of examples. Then we pioneered the transeptal puncture. That was never done before. This is in a Phantom. How to visualize, and again, based on the 3D MRA, we can segment the heart, and of course we can also identify the target area where we want or intend to puncture the septum, shown over here. That can all be done prior to the interventional procedure. And then you can advance the the needle through the septum. We applied this in pigs. It was a pig experiment where we advanced the catheter into the left atrium and finally in the left ventricle. And then we did a patient. So this was the first in-human MRI-guided VT ablation while the patient was in the magnet. This is his history. So it was an ischemic cardiomyopathy. The patient had a ICD. And what we did was 2 weeks prior to the interventional procedure, we acquired images. So this was the workflow. 2 weeks prior to the procedure, we did a workup scan to check if the images were of good quality in the presence of an ICD. So the 3D MRA was already obtained. We acquired CINES to assess the function, and we acquired a prior 3D LTE to collect data related to the arrhythmic substrate. And then during the ablation procedure itself, we acquired, again, the 3D MRA for co-registration. During the procedure itself, we navigated the catheters, of course, in position. We did lesion assessment in the absence of gadolinium, and finally we did also lesion assessment with gadolinium. These are the images acquired 2 weeks prior to the procedure. So there's substantial wall motion abnormalities, wall thinning, all features of an ischemic cardiomyopathy. We acquired 2D LGE, and I think next time you organize this, we should talk about LGE imaging, 2D versus 3D, and what that means, because I think from an electrophysiological perspective, you think bright is dead or scar, but I think we should talk about 50 shades of white, and that all these shades do have different characteristics which are relevant for your EP work. On top of that, we acquired this 3D dataset with LTE. So we segmented the leads, which is important if you want to puncture the septum. So it's all knowledge you can obtain non-invasively and prior to your interventional procedure. So the level of entrance for the interventionalist, the a priori knowledge what you may encounter is high. So that speeds up the whole procedure. And this is all acquired non-invasively. This is also again the 3D LGE acquired prior to the procedure. It's a navigator-based strategy, so it corrects for the briefing of the patient, and it gives you high-quality images. And this is the processed image data set using ADAS. You're probably familiar, but ADAS can give you the conduction corridors, but also how the extent is of the fibrotic tissue, the substrate, and if it is endo or epicardial, all relevant to prepare yourself for an interventional procedure. And remember, you can use this or reuse this information during your interventional procedure. So you're well informed while you're performing or conducting the intervention. This is how we prepare the patient. So we do this in the prep room, general anesthesia, 12-lead EKG. We have, of course, to connect the defibrillator, and in this case, we tested also the defibrillator. The patient had an ICD, so we could do this safely. We had to put on the image coils. We had to achieve the access, and then finally, we installed the patient in the magnet. And at the moment that the patient is in the bore, so there are still people around preparing the procedure, we start already the image collection. So there's no delay or whatsoever. This is how it looks like from the control room perspective, usually my place. And this is the situation for the interventionalist. So yeah, you're pretty familiar with this. And you have to remember as well that this is an older type of scanner, but the new generation scanners do have a wider bore, so the accessibility is more convenient. The length of the scanner is shorter, so the whole accessibility, the economics are way better. And again, no lead apron, just a headset for communication purposes. This is the sheath in the superior vena cava, shown over here, for the transeptal puncture. This is the positioning of the dilatator. And it's just actually the bullseye you have to hit, and then you puncture the septum, and that is well controlled because you have all this information prior to the interventional procedure itself. So that does not take much time. And finally, we did the substrate mapping based on the integration of the previously acquired 3D LTE dataset and the mapping. Just to give you a flavor, these are the signals you get with the MR-compatible intracardiac catheters. Good enough for our electrophysiologists to rely on and to perform the procedure. Maybe you can comment on that later. I'm an imaging cardiologist, but but the advantage is that immediately you can relate this to your substrate you already obtained prior to the procedure. And finally, they did the ablation, and the patient was at that moment cured. And up to now, I checked, is free from ventricular arrhythmias. Where are we now? What is the current landscape? Well, we have the hemodynamic monitoring and the 12-lead EKG in place that are MR compatible. We have a defibrillator, not yet certified. We are able to track catheters passively, so that means no building technology, or we can track catheters actively, as this is presented. We can use Northstar software for navigation purposes. One of the big limitation is guide wires. There are no certified MR-compatible guide wires available today. There were a couple of guide wires until recently, but for some reason they were took off the market. Not for technical reasons, but more for administrative reasons. They forgot to reapply for the CE mark and FDA approval. But there will be new guide wires soon. A bioptome is challenging, and I think that's another topic, of course, but there is no MR-compatible bioptome available. Catheters are available, and hemodynamic display of MR-compatible displays and audio systems are available and pretty convenient. So where are we? MR-guided EP versus conventional EP. There's no radiation versus cumulative exposure, which is still a problem. There's the direct myocardial and soft tissue visualization by MR versus indirect fluoroscopic anatomy visualization. There's the true 3D anatomy-based tracking versus reconstructed electrical anatomical maps, which does not give you the information of the deforming and displacement of the heart versus the catheter. And you try to compensate this with ICE, but it is kind of way of multi-modality approach that I would not prefer, because it is also, you have to integrate as an operator all this information based on these different screens. Well, with MR you can present this in one single display. Tissue characterization is the key difference between MR-guided interventions versus conventional voltage-based surrogate markers. You can visualize the lesions and also the gaps, and you can also do this during the procedure itself, so you are able to tailor modify your procedure based on image data while the catheters are still in the patient. And the downside, of course, is you need a good collaboration with the owner of the MR facility, usually the radiology department, and that requires some preparation before you can start doing this. But once established, it gives you also a unique opportunity to accelerate the procedure and or improve the clinical outcome in terms of reduce the redo rate. It's, I think, a holy grail. Take-home messages. You can use this for atrial and ventricular arrhythmias. Patients with implanted devices are not a contraindication anymore, so forget about that. You can do it. 3D imaging is key, including segmentation and analysis of the scar tissue. But again, that requires another discussion. Acute lesions can be assessed using different types of MR techniques, so that gives you a very detailed insight in the lesions and the components of the lesions created. And the periprocedural prediction of durable lesions is within clinical reach. So finally, I think you will be able, and your future will look like this, that by relying also on added imaging data, advanced imaging data provided by MR, you will be able to improve your clinical performance. Thanks for your attention.
Any comments or questions?
Can you show again the tracings from the MRI?
I'm not sure if we will improve our results through visualization. We have very nice visualization today. We saw during meeting at the beginning this AI eyes. Then we saw what Honza Petru did, the case with, or Sant'Angeli, Pascal, they did this eyes with merged with vlastně electroanatomical mapping system. So I think we generally need to understand maybe better phenotype the patient, especially with non-ischemic cardiomyopathy. We need better energy source to penetrate to different depths. I don't think I'm limited now by visualization. So, and you said that we need simplicities. This doesn't look to me very simple. I think if I look workflow, I cannot imagine that I do patient with a storm, electrical storm, and do all these, steps will die before we reach the cath lab. So,
to be honest, I see not the difference related to a complex patient. What I see is that still the clinical outcome has not improved with the new technology you have introduced, right? So the redo rate is still substantial.
It is coming, I think. Yeah. And if you have laminopathy, you can do any ablation. The patient will end up with a heart transplant anyway. So you have to admit that we cannot be 100% successful, especially for VT ablation. But these are just, and if I saw the signals, I can't imagine. I can see some late potentials, some mid-diastolic potentials in this stuff. So I'm a bit still skeptical.
I can imagine because it is new, but I still
not that new. I saw first presentations already long time ago about this technology. Even guys in Leipzig played with that, and I saw really several presentations. I don't even remember how long it is.
It's always the matter what is profitable, what is the future, what would you, get from this, okay? How's the price for?
Okay? There's certainly a price because there's the challenge, the complexity, the collaboration with radiology. Yeah. That's true, but if you analyze from a distance, and I'm an imaging cardiologist, so I'm an observer, what are the key components to influence your outcome? It's the accuracy of navigation, right?
What Pepa mentioned, I think that the level of simplicity, and if you can get the same result with much simple approach, this is the winner, okay?
Yeah, sure, okay. Absolutely, I agree.
We certainly will follow. We will see what's going on, but
we'll talk to Marcus.
And then maybe a few years later we can discuss who is winner.
Sure.
Thank you so much.
Okay,
Thank you. Okay, great. So last but not least, we just connect briefly to the lab, and Dan will close the case.
Are they waiting for us? Oh, great, guys. Okay, right, you're live again.
Can you hear us?
Yes, Dana.
Yeah, perfect. So very brief concluding. When we did the standard lesion set or re-ablation of standard lesion set superior inferior GP area, we retested with extracardiac vagus stimulation, and there was no response of AV node. But this was not the most important endpoint. There was still slowing of sinus rate plus minus about 10 beats per minute. So we went again to superior part of atrium. First we did if we rotate the right atrium, we did ablation around SVC. This is almost SVC isolation except the gap at the phrenic nerve because of safety. And we also extended the superior part of intercable line. And now when you look at go to left atrium only, we also significantly extended the lesion in the anterior vestibule of right veins. We went from pretty roof area to the anterior to the right inferior vein. This is much more than we normally do. And we add, even if we know that there is already non-responsiveness of AV node, we did also superior left GP ablation. It is like anterosuperior quadrant of, or sometimes it is called Marshall GP, anterosuperior quadrant of ostium of left superior vein. And even after this ablation, very extensive ablation, we retest the sinus node responsiveness, and that was still slowing by 10 beats per minute, which was plus minus the same like at the baseline. So we failed to eliminate all the responses of sinus node, and we retest with atropine, and also, as expected, after atropine, there was sinus rate acceleration again. It was a little bit weaker than at baseline, because at baseline, post-atropine response was plus 38%. After this ablation, response was plus 29. So it is probably non-significantly better. And this is the maximum what can we do. The last resort ablation would be to go deep into the superior vena cava and ablate the SVC aortic ganglion, but I have never done this because I think there is a risk of SVC stenosis. So we end up with this like incomplete endpoint, and we will see if there is a good clinical outcome or not.
So, okay,
So
thank you very much,
that's all.
Dan. I think we have to congratulate. It's quite extensive ablation. And we will see next year, during a review. So that's one reason why you should come again. And I can please you. I have already date for next year workshop, Prague Rhythm. And that will be 25th and up to 27th of April. We moved back to April because HRS moved back to May. So we have to sandwich in between ERA and HRS meeting. So that's the very last weekend of April. So mark it in your calendar. You will hear the outcome of this case. And not only that, we will have definitely some interesting program again. That brings us to the end of this 28th edition of Prague Rhythm. And I would like to thank to all of you for coming. I would like to thank all faculty because they did a very good job, and I think we learned a lot. And also I would like to thank to CCL company and other supportive companies, and namely Hanna Klimentova, who is our secretary, organizing committee secretary. She did all this logistics, coordinated all logistics. Also, I would like to thank to all sponsors. You have here on this table all sponsors, from the top sponsors up to just contributors to this meeting, because without their help we could not organize this nice meeting. And I would like to wish you a safe trip home, and hope to see you during next year somewhere, and if not somewhere, then in Prague again in 2027, April 25 to 27. Thank you very much for your attention.